Hello, everybody. I want to welcome you to the Resident and Family Support Council. This meeting is held every other Tuesday, and the purpose of this meeting is to empower people who live in long-term care communities, as well as people who care for somebody in long-term care communities, with information so that they can help advocate for themselves. And it's presented through the Illinois Long-Term Care Ombudsman Program. And if you would like more information on that, you can go ahead and you can look in the chat. We'll be sharing information in the chat on how you can get a hold of the local ombudsman in your area. We do have some people that are monitoring the chat. So throughout this presentation, do feel free to go ahead and use that chat to help communicate any questions that you may have, any comments that you may have, any resources you may have. That's what this meeting is all about. It's all about making sure that we're sharing information with each other so that we can live that better life as we navigate that long-term care road and highway. So I just, before we get into today's topic, I wanted to go ahead and just let everybody know about what the next meeting's topic will be. The next meeting will be held on August 31st. And that meeting's topic will be on dementia-friendly Illinois and becoming a dementia friend. It's a really important initiative for Illinois to become a dementia-friendly state. So we'll be having Susan Frick from Rush Alzheimer's Disease Center and the Illinois Cognitive Network provide us with information on how we can go about supporting those who have dementia that live in our state. So I will go ahead right now, and we have Katie on here right now. Katie Harrison, are you on? Katie's going to be presenting for us today. Katie, are you on? If you're on, you could go ahead and unmute yourself. Katie? I do not see Katie on here. Okay, so let me see. We could please hold on for a minute while I go ahead and I see what I can do to find out what to do about Katie not being on the call. I apologize to everyone for this. I am getting a hold of her right now, trying to see if I can get a hold of her. So please bear with me. Katie, are you in the call from the Hospice and Palliative Care Center? Are you on the call? If you are, could you please unmute yourself? Carrie? Could you unmute yourself?
I'm here.
Okay, Carrie, could you get a hold of Katie? I just tried calling. It's Kate. Do you have Katie's number?
I believe so, but isn't it also, is it the Katie Townsend that's down there? Because I don't see.
Yes, I thought it was Katie, but she is not unmuting herself. Katie, can you?
I'm looking to see if I have a phone number. Hold on.
Okay, because I'm asking her to unmute. I apologize for this, everybody, but I'm asking her to unmute. And I don't know if she's having technical difficulties or what. Katie, could you go ahead and type in chat if you're having issues? I'm apologizing to everybody for this.
I'm trying, let me look into, I think I have her contact in my Gmail stuff.
Okay, I'm wondering if she's having issues getting connected.
Can everybody hear me?
Yes.
Can everybody hear me?
Yes.
Okay, so just when I was a kid, there was this TV show that they decided to do their 100th episode live, and they said anytime that we have an error, we're going to have a dancing monkey come on the screen, and I guess I get to be the dancing monkey today. Just to give you an idea of actually how improvised this is, I'm sitting in the middle of a park in Pleasant Hill, Illinois. Didn't even know if I was going to make it, but so the I hear a lot about different little things that, when it boils down to it, is a maintenance issue. One of the top things I hear in nursing homes is when residents say, "Oh, the staff slammed the door." We keep telling the staff, "Don't slam the door," but they still slam the door. I go in and I see signs everywhere, "Don't slam the door." Well, when I see that, I know that chances are the staff are being really careful, because they've been told a million times already to not slam the door, and they're real careful to shut it slowly, but it still slams. And so what's happened, and not all doors have this, but a lot of your institutional doors have these little rubber bumpers on them. And I believe they're called a door silencer. And what it does is it just provides a cushion for when the door shuts, and it softens the blow of the door hitting the metal frame. Over time, those things get painted over. They get, since they're rubber, they get hard, and they amplify the sound as though they weren't even there. And so when I get complaints about doors being slammed, the first thing I look at are those rubber bumpers. Have they been painted over? Are they old and hard? Are they crushed? And do they need to be replaced? I mean, you can get 100 of them for a few bucks. So if your loved one or your residents are complaining about the doors being slammed, that's the first thing to check. It's like a 5-minute fix to go through and change a bunch of door bumpers.
So Stephen, if you would like, I just found your PowerPoint. I could put it up.
Hold on. I have an email from Katie that she's having a hard time getting in from the link. Let me send her the right link first of all. Okay.
Okay.
And then let me figure out what I did with her phone number to make sure I have the right. At least I'm headed there, guys.
Okay. So
awesome. Yeah. So Lee, if you want to put up my my presentation, then I can improvise a little less. That'd be great.
I will go ahead and I will do that right now for you. Okay. So here we go. I'll let you know. I don't know if you can see this because you are calling in. I'm not sure.
Yep, I can see it. Perfect. All right, so just keep scrolling through. All right, so that's what I'm talking about. That little bump, and you can see that door silencer is just it's tired. It's worn out. I had complaints left and right from this facility, and I snapped that picture and I took it to maintenance and I said, you guys got to replace these. And they went through and they replaced a bunch of them. And what do you know? No more complaints. I can't remember. I think I've got a few bullet points on this slide. If you could click.
So I can go ahead and I can help explain some of that for you, since you might be having difficulty on your phone seeing everything. One of the things
Oh,
that happens is
I can see it. I'm on.
Okay.
Hey Lee, I'm on my iPad, so I can see all of it.
Okay, great.
And then, yeah, go ahead and go to the next slide. So another thing to look at if you have issues with the door slamming is the latching speed. And Lee, if you want to go ahead and click through a few of the bullet points. So the doors have to close in a certain amount of time in order to meet fire code. And so if you look at this picture on here, that's the sweep speed for the most part. You can adjust what's called the latching speed. And that's, next time you go and you have a hydraulic opener on a door, throw it open and watch as it closes. And you'll see 2 to 3 distinct things happen. First is it's going to swing open and then it'll slow down right before it opens all the way. That's the back check. Then it's going to swing real fast, and then that third part, that latching speed, is where it slows down right before it closes. So if you've got a slamming door, that might need to be looked at. Some doors also have a spring adjustment. So if your door's really heavy and your loved one can't get through it, that might be something to look at. The spring adjustment isn't on every, it's not on every single door, but it's something to look at. So let's go ahead and go to the next slide.
Stephen, if I could just share
Hey,
a quick
Lee.
story. Oh, go ahead.
I'm on the phone with Katie. I don't know what link you sent her, but it had her sitting in a waiting room. We're working it right now. Hopefully we'll be here in a minute.
Okay, sorry about that.
Okay.
I don't know either. I apologize. Okay. If I could just share a quick story too about this door. Also, a lot of times these doors squeak. They get a squeaking noise, which can kind of be like a little, excuse me for mimicking the noise, but that kind of a noise. And the reason why I demonstrated that is I was working with a dementia patient one time who kept talking about the cat that needed to go out. There was a cat that needed to go out of the room. And as the team started, and actually was having falls related to that, because she was getting out of bed to let the cat out of the room. And it was every time staff were coming and going, the door was squeaking, and it was actually making it sound like a cat. And it was the maintenance man who, when the team went to the scene of the crime where the person had the fall, he recognized that the sound, and he's like, that could sound like a cat to somebody. So a simple oiling of that door actually remedied this lady's fall problem. So that's a really unique team approach to understanding that this door maintenance can be extremely important for sleep quality, for people falling, and it just can give people a better quality to their lives. So I thought I would share that little quick story.
Yeah, that is I never even thought of that. I haven't had that come up before, but it's sometimes the problems that our residents are having are easily solved with some basic maintenance. So that's great.
Yeah.
Yeah, go ahead and go to the next slide, please. Lighting. So fluorescent lights have a flicker to it, and you see fluorescent lights everywhere in institutional buildings like nursing homes. They flicker at about 120 hertz, but that flicker gets a little slower as the bulb gets older. Fluorescent bulbs also tend to be very bright. Some people are sensitive to the flicker, and the brightness and medications can sometimes make this worse. I was actually looking for a list of medications that can bring about photosensitivity and flicker sensitivity, and the list was just too long to include on the slide. So, if your loved one has gone through a medication change, and all of a sudden they're having these migraine headaches, it might be worthwhile to look at the lighting and see if maybe mom needs a lamp instead of the bright overhead light. And anytime I see a flickering light in a resident's room, I tell the resident, I'm going to let maintenance know about your light and that it needs to be replaced, because people shouldn't have to sit under a light that's constantly flickering at them. So that's something to look out for and consider if your loved one is getting headaches, or even nausea can be triggered by flashing lights. So go ahead to the next slide.
Recording in progress.
And there's also, sorry. Okay, so there's also something I wanted to bring up regarding this as well, with the lights. And lights as well can also, when there's such bright lighting, if you think about this in a hallway in the middle of the night when somebody's trying to sleep in their room, and the effects that can have on somebody in a dark room and seeing this bright white light coming from the hallway. And again, there's been some falls studies through the University of Wisconsin, and they have actually attributed falls to having light in hallway, that people are not getting quality sleep because that bright light is filtering into their rooms. And because people aren't having quality sleep, then they're more drowsy through the course of the day. And then that also leads to not being as alert and oriented throughout the course of the day, and has produced falls for people. So they've done simple things by, like what you said, Stephen, by putting lamps in hallways, by shutting down those fluorescent lights at a particular time of light, giving staff flashlights to be able to use instead, to help navigate their safety as they're going through the hallways, but to really try to look at that, minimizing that fluorescent lighting. It can have more importance than just being irritating. It can also actually provide somebody some different quality to their life. So it's another point worth noting.
Yes, and we had a question about will we be hearing about hospice and palliative care today? We are working on getting.
We are working on
her
it. It's just one technical issue where hopefully we're there in a second.
And Carrie, she probably joined through the meeting that we had last week instead of the other link that was originally sent. So it probably got lost.
She's coming in right now. Yes, the only link she had was the WebEx.
Okay.
Are you in there?
Okay, perfect.
There she is.
Okay, perfect.
So, and that's perfect timing, because I think this is my last slide. There might be one more. So, some action steps that you can take on these little maintenance issues. First of all, document your concerns and the steps that you take. Document. It's really important. The ombudsman, we want to see that you've tried, if you're comfortable with trying. Public health wants to see that you've tried to take steps. So always document. but after that, your first step is going to be to ask staff to file a maintenance request. It's probably better to talk to a higher up staff than a CNA, because we all know that CNAs are already running around like crazy trying to meet everybody's needs. If the staff don't get to you, get that maintenance request filed, talk to maintenance directly or speak to the administrator. If those action steps don't work, you can file a complaint with public health, because you're looking at possibly quality of life issues, potential accessibility, or even safety issues. And of course, you can talk to your ombudsman, and we can try and advocate for you on your behalf. I believe that's my last slide. If not, I
Okay.
can talk through the next one too.
Nope,
But
that's it. We're
perfect.
good. Stephen,
So
thank you
I'll
for taking
yield
the ball.
floor.
Thank you for taking the
No
ball and running with
problem.
it. And again, I
No
apologize to
problem.
everybody. I just want to make sure that, Stephen, that was wonderful that you were able to do that. And I just want to make sure that I just explained to those who came on late that we did have an issue, and I apologize extremely for that. Katie, I apologize for putting you in that position where you probably were freaking out. So we will go ahead and we will begin our presentation on hospice and palliative care and understanding the difference. Welcome, Katie. Thank you very much for joining us. I hope you're able to take some deep breaths. And if you want to start sharing your screen, please feel free.
Oh, no, thank you. Thank you so much. No, I apologize. I was in the wrong, I was in the wrong link. So I apologize on that. But yes, my name is Katie and I am with Heartland Hospice. Can everybody hear me okay and see me okay?
Yes.
Okay.
We can hear you. Thank you.
Perfect. So I'm going to just do a hospice 101. So I'm going to, of course, because I've been doing hospice work for 5 years, I'm really obviously partial to how my company works, but generally, hospice is a Medicare benefit, so we'll kind of dive into that. And so it's a little mostly the same across the board. However, each company has their little specialties. But I'm going to kind of just do a quick overview. Hopefully it won't be too overwhelming or anything. And then we can open it up for any questions, that you guys might have if that works for you. Okay, so the perception of hospice is very different than the reality. And I can speak for myself personally because 11 years ago when I graduated nursing school, if anybody told me I would be doing hospice work, I probably would have laughed in their face and been like, there's no way I'm doing that. But the perception is, you're on hospice and you are dying tomorrow and it is strictly end of life and everything must stop. And that's it. It's the end of the road. And in reality, that's not true. What hospice is it is an extra layer of care and support for your loved one, as well as family members surrounding that loved one, friends surrounding that loved one. So it is comfort focused, yes, but that does not mean that things have to stop, that care has to stop, that we are not going to be treating the patient and helping them along their way. So like I mentioned, hospice is a Medicare benefit. It's Part A. And oh, can you guys hear me okay? I just got a thing that can you still hear me good? Yes, okay, thank you. So it's a Part A benefit. And what that means is we come in as hospice, there's a whole team of us, and we come in as an extra layer of care and support. So it's wonderful what you can get when you're on hospice. We focus on quality of life. So yes, it is comfort focused. We are not going to do active treatment in the sense of curing somebody. But what that doesn't mean that we don't care for them if they have an infection, if there's anything that is making them uncomfortable, if they, let's say, have a feeding tube that they've had for many, many years and they're just not ready to end the feeding tube, but they have other diseases that are covering or that are needing hospice benefits. That's where we would come in. I see a question popped up. Do you want to do questions at the end, or do we want to?
Yeah, we could do questions at the end.
Okay. I just saw one pop up, but we can just do it. Well, I'll kind of run through it. Okay. So,
Well, unless if you feel that it's better to address it while we're in the topic, feel free.
okay. I think I just happened to glance down. I'm sorry, my screen is looks a little different because I had to jump onto a different device, but I saw that it said, is it covered under Medicaid? So Medicaid is, yes, it can be under Medicaid or Medicare, but it's a Medicare benefit. So typically when you come onto hospice, whatever company runs the insurance, because unfortunately we have patients who are younger than 65 that come onto our services, and then we would run their insurance to see if there's a copay or any deductible, or if our company qualifies them, if they're covered with the insurance. So we would look into that, but we do have patients who have Medicaid, yes, and Medicare. I hope that answered it and wasn't too confusing. But so when you come onto hospice services, what it means is there's a 6-month life expectancy. And I always like to touch on this because it's very confusing for people. So what it means is your diagnosis, whether it's a cancer diagnosis, a heart failure, anything, is if we did nothing for you, if we sat and put your loved one in a chair and did not provide them any medication, any care, any food, nothing, would they be able to sustain their life for 6 months? Probably not, because they wouldn't be able to, maybe do certain things, or the disease would progress. So what it doesn't mean that, well, yeah, I can see them still being here in 6 months, but you're telling me they have 6 months or less. That's just if we did not treat them for their disease or for any care for them. So realistically, we have patients that are on our service for many years, 2 years, 3 years, because we come in and we work as an advocate with the family. We work with the physicians, we work with the facility if they're at a facility. And these patients tend to do a little bit better with the extra care and support that we provide, along with the entire medical team and their family. I know that's a little bit, that might be confusing. So if I need to go back and reiterate that, I can, but it's a wonderful thing. So it's 6 months or less if we weren't treating or helping manage symptoms. What we do is we come in and we try to keep the patient out of the hospital, keep them in their home setting, whatever that may be, whether it's a loved one's home, their own home, or a facility. And we are not going to seek active curative treatments. But if they have a urinary tract infection, we will treat that. If there's certain stipulations that they have that they are needing, assistance with, we will care for them. Does that make sense? Is everybody, are we, okay. So I'm just going to dive into the hospice team. So when someone comes onto hospice, there's a whole team that they are allowed to have if they so want it. And I have a little, I can send this in an email too, but I just have, this is our personal handout. And so what it does is it just kind of gives everybody a general guideline of the hospice team. I'm not going to spend a ton of time on it because we'll be here forever, but I'm just going to kind of skim through who is on that team. And so everybody that comes onto hospice gets a nurse case manager. The nurse case manager runs the show of the whole team. She will come and see your loved one a minimum of twice a week. And that is for somebody who is doing very well, who is very stable, and doesn't need a ton of extra help at that time. So the nurse will come twice a week. Now, the nice thing is with hospice is it's very individualized care. So what we do for one patient who has dementia is going to look 100% different than another patient with dementia, because it looks different in everybody. It's not the same situation. So it's very individualized care and focused on what your loved one's needs are. So there might be a patient that has a lot of wounds or needs a lot of extra support with other medical problems on top of the dementia that they might have or something. And our nurse will come and increase her visits based off of their needs. So 1 week, if they're having an upper respiratory infection, maybe they caught a cold at the facility, the nurse will increase her visits maybe 3 or 4 days that week, maybe 5 days that week. Then the next week, maybe they're doing wonderful. Then she'll come only 2 days that week. So it's a minimum of twice a week. As the disease progresses or things start to progress and we're looking like we're getting closer to the end, the nurse will come every single day to see your loved one. And I'm going to dive into our after hours in a little bit. So we'll kind of touch more on that, but the nurse will come every day. Then we also have a CNA or a caregiver that would come and provide bed baths or showers or just kind of what we call activities of daily living for that loved one. Also a minimum of twice a week. Again, it's individualized based off of the care that the patient might need, but it will be a minimum of twice a week. And if the patient or, if your loved one is in a facility, I just want to reiterate before I get too deep that none of the care at the facility changes. So we do not take over. They will still provide all the care. We just come in as that extra layer of support. So nothing would change for the care they're receiving at the facility. This is all in addition to what they've already been getting from the facility. So I just kind of wanted to touch on that. But the CNA would come again twice a week. Then we have social workers and chaplains or spiritual care coordinators. And what their role is not every family dynamic is ideal and perfect, and not every facility is perfect, of course, and all of that. So our social workers and our spiritual care coordinators are designed to work closely with the family, with the patient, anybody in the community. They can provide resources as far as additional services or care that you guys might need for your loved one if they are in a home setting versus a skilled nursing facility. And the chaplains, the spiritual care coordinator's role is really just to be as religious or spiritual as the patient would want them to be, or really not at all. So we cover a wide range. Some people will say to me, don't come close to me with the Bible, and other people, that's all they want to do is pray. So we are designed to meet them wherever they are at along this process and kind of help guide them with whatever services they need. Now, sometimes we have where the family member, maybe it's the daughter is very religious and needs that extra prayer, but the patient doesn't want that. And that's fine too, because we are not just taking care of the patient, we're taking care of the family as a whole, or the, friends, anybody that's involved in the care. We also have nurse practitioners and physicians. So we work closely with the primary physician for the loved one. Maybe they've had a physician for 50 years that they really love and trust. That is wonderful. We work closely with them. Our physicians and nurse practitioners are more designed for that 3 o'clock in the morning. You can't get a hold of the primary doctor and your loved one is in pain or is needing an antibiotic right away. We can utilize our team to get those orders so that we can keep them comfortable and make sure that we're caring for them with whatever they have going on. Our nurse practitioners really good at being a set of eyes for the loved one. So sometimes their primary physician can't physically come into the facility to see them or lay eyes on them. So they rely on our nurse practitioners to do the head to toe assessment, to assess the patient and report back to the primary physician. We also have music and massage therapy, which is wonderful. So our music therapist is a board certified music therapist. She doesn't just come and play music that they would love to hear, which of course she does do. However, she really focuses on if they're having anxiety, if they're having pain, if they're feeling restless or they're antsy and can't really get situated or comfortable. She's designed to come in and really provide some therapeutic music to help calm them. One of the things that we don't want to do is just load them with medication if they don't need it. That's not our goal. Some patients, that's what they need is medication, but we don't want to do that as a first resort. So the music therapy can be wonderful. The massage therapy can be wonderful. Some other hospice companies have pet therapies, and there's all different specialties that they have in addition to the core case manager, CNA, social worker, and chaplain that can care for them. We do have bereavement support. So bereavement support is really designed for any of the family members, not so much for the patient, but the loved ones surrounding the patient. And bereavement support does not have to start after the loved one has passed away. It can start the day they sign up for hospice, or 6 months down the road, or a year down the road. Whenever the family feels they need it, bereavement support is available to them. We also, our bereavement team will follow them even after their loved one has passed for at least a year, if not longer. Again, it's very individualized, so depending on the need of that family. We have pharmacies that we use in an emergency situation where we need to get a pain medication or an antibiotic or something to the patient right away. We have pharmacies that can deliver the medicine in approximately 2 to 4 hours. That's a very quick version of our team. I'm sorry, I would like to dive in, but I could talk for probably 3 hours about this. So I'm going to try to keep it short, but that's the hospice team. And again, it's give or take. So every patients can have all of these services or none of these services. And it's just amazing. I'm going to transition into what hospice, or what's covered under hospice, because I think that that's huge for a lot. So in addition to that whole team I just talked about, again, you will not receive a bill from hospice. Hospice is a Medicare Part A benefit, so there's no bills from hospice, but we cover the cost of any medications that are related to the patient's hospice diagnosis and other diagnoses that fall underneath the primary diagnosis. So the easiest way to describe it to everybody, if I just being completely transparent, hospice pretty much covers all of the medications except vitamins. Sometimes they don't cover cholesterol medications and sometimes thyroid medications. It just depends again on the patient. But anything with the heart, the lungs, the bowels, constipation, diarrhea, pain, oh my gosh, anything, we would cover the cost of. So even if there's a Walgreens there's a Walgreens 5 minutes down the street that can have the medication within an hour, we would cover the costs and you guys would be able to pick it up for your loved one instead of having to wait the 2 to 4 hours. So we always are getting the medication as quick as we can, wherever that's from, whether it's the pharmacy or from our specific pharmacy, but that's, it's amazing. So any medication we would cover the cost of. Any equipment, meaning a hospital bed, a wheelchair, oxygen, walkers, portable oxygen tanks, anything that your loved one would need, Hoyer lifts, sit to stand lifts, any specialty devices that they might need to help them on a day-to-day basis, hospice covers the cost of. The nice thing about that is, let's say your loved one needs a special wheelchair, a high back wheelchair, which is a little bit different than a standard, and it gets delivered to them. They try it out. They realize that they do not like it. It's uncomfortable. It doesn't work for them. All we do is reorder a different wheelchair and swap it out. There is no limit to the amount of equipment or supplies that you can have in a day in a hospice setting, nothing like that. So it's amazing, because sometimes we have to trial and error for different patients that may need different needs. So that's what's wonderful about equipment. The other thing, the last thing that we kind of cover is any supplies. So I always tell people we take care of patients wherever they call home. And in very sad cases, we've had patients on our service that are actually homeless, and we've cared for them in hotels or in the back of their minivans. And so our supply list that we cover is anywhere from a hair comb to wound care supplies. So wipes, gloves, shampoos, creams, lotions, diapers, any bed pads. We kind of cover any supplies, and we would order it directly to their home or to wherever they call home. And it takes about a day. So it's really wonderful, everything that could be covered, and then the additional support that you get from hospice is huge. We do have different levels of care, and I'm just going to briefly touch on levels of care with hospice. So when someone first signs on, we are constantly evaluating that patient for what level of care they need, what's going to give them the most support and the most help and keep them comfortable. That's our main goal. So we can do routine level of care, which is what about 99% of patients are on is routine level of care. There's also general inpatient level of care, which is if somebody is having or experiencing symptoms. Let's just use pain as an example, because that's the easiest one. And we cannot keep them comfortable at home or in a setting, where the hospice nurse is there trying to give them medications. And we are making the decision as the hospice team that this patient needs to be either placed in the hospital or placed in a skilled nursing facility under general level inpatient care. And what that does is that allows hospice to care for the patient, and we actually would cover the cost of the room and board or the hospital stay if need be. Now that gets a little tricky because Medicare, there's certain restrictions that Medicare requires that the patient would have to meet to be able to have general level inpatient care. So we are constantly evaluating, is this a patient that would meet this criteria and that would need this level of care? It does not happen often. I will tell you, one of the things that we do is under routine level of care, the hospice nurse can come in and see the patient, and they might be with the patient for 2 hours, and the patient's very uncomfortable. That hospice nurse is not going to say, well, I'm sorry, Mr. Smith, I've been here for 2 hours. I have to leave. I'm sorry you're still in pain. Good luck. I'll see you tomorrow. Never. We never leave a patient uncomfortable or with active symptoms. So even under routine level of care, we are constantly making sure that our patients are comfortable and that the family or the facility is comfortable when we leave. So GIP level of care, that general level inpatient, it typically, that's why it's not super common, because 9 out of 10 times we can get that patient comfortable when we're there for that visit and have a plan in place. We also have respite level of care. And what respite level of care is really for patients who maybe are living at home or with their loved one, and it's kind of a caregiver burnout relief. So it's 4 nighs and 5 days that the patient would go to a skilled nursing facility, and that hospice would cover that cost, those 4 nights and 5 days. And there is no restrictions as to how many respite level of care they can have within their hospice setting. However, Medicare always looks at, you can't just respite them back to back to keep them there for 3 months. So there are a little bit of stipulations, but there's no limit. It's all based off of whatever the need is and the situation at that time. What else can I tell you guys about? I'm just kind of skimming through. I know I'm throwing a lot at you guys.
Katie, will you really go into what palliative care is and how it works?
Yes.
That's important.
Yeah, so palliative care, a lot of people, thank you, Carrie, for bringing that up. So palliative care is wonderful. Anybody can have palliative care. A lot of people associate palliative care with hospice, or palliative is the, pre-hospice. Incorrect. What palliative care is it's essentially designed I describe it as kind of a quarterback. Like, so a football team, there's a team of physicians, right? You might have a primary physician, a cardiologist, maybe an orthopedic doctor. Let's say you fell and broke a leg and you're having surgery, and you have all these different team members. What palliative can do is palliative comes in and they help be an advocate for you and your loved one, but they also quarterback the whole team and the whole plan of care. So a lot of patients use it for situations where maybe they're in the hospital and they have a lot going on. There's a lot of different hands in the cookie jar, and they want somebody to kind of oversee and overview the care. Palliative also is used for symptoms that need to be managed, such as pain or difficulty breathing that maybe somebody is experiencing, after they've had that surgery, they've had their leg, repaired, they're back at home, they're really struggling, they're having a lot of symptom management with the pain, but then they also have a history of asthma, and now they're kind of trying to juggle all of these things going on. Palliative is wonderful at helping come in, manage those symptoms, get them medications if they need them, assist them with what might work, what might not work. And what that looks like, palliative is really a nurse practitioner that comes into the home or to the hospital or the setting. It's a team. Typically, though, it is the nurse practitioner that comes in, and she would come in weekly for that first month or two, or however long she needs to get that patient at more of what we would call like a baseline level with their symptom management. And then once the patient is fairly comfortable, doing well, they're feeling like they're grasping their care, the nurse practitioner for palliative comes once a month. So it's not as much support as a hospice type setting, but again, not everybody needs palliative before they have hospice, and vice versa. Palliative is a completely separate entity that I feel like it kind of gets clumped with hospice. So palliative is really just designed as extra support for guiding and planning, what the patient's goals of care are. It's just not as much of a team as the hospice team, if that makes sense.
There's another question in there that was asked. Can dementia be diagnosed as hospice level, and at what stage in the illness? Can someone be diagnosed for hospice at some point?
Yeah, so that's a great question. So there are certain primary diagnoses that we can use for hospice and certain ones that we cannot. For example, we might have a patient who's 92 and just really is given up with life. They don't feel, they're just kind of done, and they have what we call failure to thrive. So prime example, failure to thrive is not a primary diagnosis for hospice. So we cannot use it as a primary. However, we can use it as a secondary. So what we do when we come in and do an evaluation to see if somebody is eligible for hospice is we're looking at all of the diseases. So do they have dementia with behaviors, dementia without behaviors? Where are they at on their Alzheimer's level? A lot of people associate Alzheimer's and dementia as one diagnosis and one disease. It's not true. It's different. It's different, and it looks different depending on the patient. So what we do is sometimes I've had patients where I've gone in and I've done an assessment and I've reviewed their chart, and I will say, oh, I think that they're definitely hospice eligible, but we're going to use a primary diagnosis of cerebral vascular disease. And they might say, well, my loved one has never had a stroke before. Or we might say, oh, let's use heart failure. Well, they've never been diagnosed with heart failure. And that's okay. This is just the hospice diagnosis. And what it is whatever we're seeing at that time of evaluation is what we're going to use. And then we can secondary and piggyback all of maybe their medical history. So for dementia, what we do is you can use dementia. There's frontal temporal dementia that is more behavior focused. If somebody is having a lot of paranoia, anxiety, or just, maybe sundowns very badly, or has the dementia, where they get restless and different things. So we can use it. And then we can also piggyback other things. We can also use Alzheimer's disease as a primary. Alzheimer's disease there is what we call a FAST scale that we use. And it's just a quick reference. They have to be at a certain level. And so if you're wondering what that level would be, it is a little bit different for everybody and where they're at in the process. Because with Alzheimer's, they can kind of stay at one level for an extended period of time before their disease progresses. So typically we look at, okay, are they incontinent? Are they able to feed themselves or not? Are they speaking 6 words or less? There's all these different things that play a role, but what we do is that's part of our assessment when we first come in to assess for eligibility is what would be the best diagnosis. So yes, we can use dementia, we can use Alzheimer's, we can use many different things. It's just finding what's going to work. And the nice thing is we can go with like a frontal temporal dementia, but then maybe the patient ends up showing more disease progression of heart failure. And then we can easily switch that, talking with the doctors and say, can we switch their primary diagnosis from, dementia to heart disease? Now that doesn't really change anything other than, we can keep them on services and qualify them as long as we're seeing the changes related to that diagnosis. Does that make sense? Or that disease process?
Katie, can palliative care go into a facility?
Yes. So palliative care can go into facility. The nice thing is, and I apologize, you guys, I should have said this when I was talking about palliative. The nice thing about palliative is Medicare B, Part B. So you can actually, when you're on palliative, you can still get home health and you can still have active therapy. Like when you're at a skilled facility, you can still receive active therapies and be on palliative. Where you can't do that is when you're on hospice, you can't have active skilled therapy days because you can't bill Medicare twice for the same part, if that makes sense. And I apologize, I should have said that sooner. So for example,
About Medicaid.
Yep,
Medicaid.
same with Medicaid, yes. So Medicaid, typically, depending on what you have for Medicaid, will cover like somebody's room and board, and then the hospice benefit still comes in. One of the things I forgot to mention when I was talking about hospice, and I also forgot to mention our 24 hours, but I'll dive into that. So when you're on hospice, you cannot be admitted into the hospital and be on hospice. So my easiest example to explain this to you guys is if your loved one is on hospice and they fall, and let's say they cut their head and they clearly need stitches, we're obviously not going to say, well, they're on hospice, they can't go to the hospital to get stitches, we're just going to have to let them bleed. That is 100% not the case. What we would do is they would go to the ER, they would get stitches, staples, get all fixed up, whatever they would need. And then they would come back to the facility or back to the home. And that's 100% fine. It's covered by hospice. They can go to the ER, get their stitches, and come back. Where it gets tricky is if they fall, they break their hip, and the doctor at the ER says to the family, oh, this is a great surgical candidate. We want to do hip surgery. And the family agrees to the hip surgery, which is fine. All they have to do is that loved one, that patient has to come off of hospice to have the surgery, because you can't have Medicare be billed twice for that. So they would revoke from hospice services, go into the hospital to have their surgery, get their rehab, get treated, all of that, and then they can always come back onto hospice. Does that make sense? I think there was a question I missed, maybe.
No, yeah, I think you got it.
Okay.
There was a question that came up in the box that said, I thought they could go to the hospital for that IP level you referenced earlier.
Yes. So that is different. The general inpatient level of care is when hospice is making that decision that they need the hospital level of care to treat whatever symptoms. And in those cases, hospice would cover the cost of that. If somebody is needing, our goal with hospice is to bring the hospital to the loved one, right? We're trying to keep them out of the hospital. We're bringing everything into the home, IVs if they need it, pain pumps, all of these things. But some patients are already in the hospital, and or all of the equipment that we're bringing into the home isn't working for them. So then if we as hospice are talking to the physicians and saying, look, they need to be actually in the hospital where there is 24-hour nursing care until we can get these symptoms managed, that is different than if they are choosing to have hip surgery or to be admitted into the hospital for active treatment. So active treatment versus comfort treatment to get them comfortable is a little bit different. I hope that's not too confusing.
That helped clarify that. So
Sorry.
is there a certain amount of days that somebody can be on hospice and or palliative care?
No. So we've had patients, I will say we've had patients graduate from hospice. It doesn't happen often, but we have had it. So I don't want to mislead anybody because, again, everybody is different. And we've had patients who really ended up just thriving. But we've had patients on, the longest patient we've had on service that I personally have experienced was 4 years. And it was really just, we were able to show Medicare, like, yes, they are declining, but because of everybody's love, support, care, the whole team, they've just been able to slow down the progression. So there's no limit, but they do start to, after about 2 or 3 years, they kind of, Medicare will look at them a little closely and say, are we seeing the decline? As long as we can see the disease progressing, they're fine. Same thing with palliative. Palliative, there's no limit on how many days, there's no restrictions or anything like that. Excuse me.
So,
Katie, let me ask you a question that I think probably everybody's wondering, or I hope. So when you guys are in the facilities right now because of COVID, because of what the last 18 months has been, do you find that it is helping more people get access to their loved ones under compassionate care or essential care, but probably more compassionate care in Illinois?
Yes. So what I've seen personally is when a loved one from a facility comes onto hospice services, and again, I don't want to speak for every facility because they all have their own protocols and policies and procedures that they follow. But what I have seen is in my facilities, when a loved one comes onto hospice services, the facility will allow the family to come in. They might have visitor restrictions where only 2 family members can come at a time, but I have seen it help our patients that are on our services because the loved ones are able to come in. And I've also seen, where families are like, hey, we want to see if our loved one's eligible because we haven't been able to see them for 6 months or a year. And if they're eligible and they can be on hospice, this is a great, there's no negative to hospice. A lot of people will ask me, well, what's the catch? And I'm like, well, there is no catch, or I've had patients say to me, I'm not dying. I don't need hospice, but I want your free hospital bed. So that's why I'm signing my consents for hospice.
So, and I've been strongly recommending to people, meet with hospice, see if, because unfortunately it's a back door in right now.
Right. Right. And and it's all about it's not so much about them dying, right? It's about their quality of life, keeping them out of the hospital, keeping them, comfortable where they call home, but also helping them. We're not going to leave them uncomfortable. And one of the things too, for my company specific, and I'm sure there's other companies out there, the patient does not have to have a DNR or a do not resuscitate or a pulse form. Everybody calls it something a little different. They can come on our services and be considered a full code and they do not need to have that DNR sign to come on. And they can still have their feeding tubes. We have patients who still get dialysis. And so that's not typical for every hospice company. But that's why I'm a big fan of patient choice. And I think that a lot of families and patients don't realize they have the choice to choose what hospice company they use. You don't have to go with whomever.
Clarify that again. Say that again for them, please. Because that's the
Yes.
other thing that I tell people all day long.
Yes, patient choice. I'm a huge fan of it. I encourage people interview different companies. It has to be the right fit, has to be the right vibe for you guys, and it does not have to be who the facility says they use. And every company, like I said, hospice is the same across the board in the sense that we all promote comfort focused. That's our philosophy, is comfort. However, every company has their little things. Some companies won't do feeding tubes. Some companies will do feeding. I mean, you have to find what is going to work for your family and your loved one. But I am a huge fan of choice, and know that nobody can tell you that you don't have a choice, because you can interview 20 different hospice companies if you want before you make your decision. You do not have to just go with one. You have that option to pick whomever you want.
Right. And just so people understand, hospice, palliative care, any of it does not have an age restriction. My son and I started with a palliative care team at 21 years old.
Yes.
So, and they followed him for a lot of years. So it is, anybody that could qualify, there's great benefit from it. And, especially, which is why I always tell people, ask for hospice, ask about palliative care. Palliative care is not hospice.
Right. Yeah, that's the big misconception, is a lot of people think palliative is like a pre-hospice or connected to it. And yes, in some cases, of course, people start on palliative and end on hospice. Unfortunately, that's, maybe their disease process and how it works out. But no, young people in the hospital that have a lot going on. My neighbor is handicapped. She's 5. She has a palliative care team. There's no limit.
Well, so what would you recommend then to anybody who's, on the call today? How would they get the process started? If they live in a nursing home right now, let's say, what would be the first thing? A family member, my loved one has dementia with a lot of comorbidities. What would you say would be my process for getting started?
Yeah, great question. So if they're at a facility, and they've maybe been there an extensive, a certain period of time or a decent amount of time, where you feel comfortable going to the clinical team there, whether it's the director of nursing or just the nurses on the floor that maybe see your loved one every day. If it's something you're thinking about, you can always say, hey, I was looking into, I've been hearing more about hospice. Do you feel my loved one would benefit from it, be eligible for it, however you want to word it, and see if they would say, oh, I think, that would be a great option for them. That's one way you could go about doing it. The other way is talking to their physician directly and just say, now some physicians are not as comfortable with hospice, right? You would think that they would be, but a lot of physicians are sometimes like, ooh, hospice. Their perception of hospice is very different than what it is. But if you can connect with the primary and just say, my mom's been falling, she gets anxious at night. I know you guys are trying everything you can to give her medication, but I'm so sick of her going to and from the hospital every time, because the facility, has to follow their protocols and send her out because, she hit her head. If I did hospice, because typically when someone's on hospice, they always call hospice first. Hospice becomes the 911. They don't go to the ER every time they fall. So that could be talking to the primary physician. All you really need is a name and where they're located for a hospice referral. And then once the hospice company gets involved, we can work on that. So we have families call us directly, not even the facilities, and they'll say, my loved one is in this facility. I want to see if they're hospice eligible. And then we can work with the family and the facility on the next step. So really there's no easy way or right or wrong way. It's just whatever your comfort level is. Now, if they're
I want to interrupt you again, Katie,
Yeah.
just for that. So, and only from experience, guys, that I know this, the facility does not get the right to tell you, oh, we don't think your loved one's ready for hospice, or hospice only comes in when we call them. No, you have that right to make that call yourself. And like Katie has said over and over, you can choose your hospice company. It is not a facility's decision, because I've heard a lot of that. And I know somebody personal who called in hospice, and the director of the facility is like, oh, he's not ready for hospice. We don't want him here. Sorry, mom wanted him there. End of story. So,
And
to make sure.
do you need a doctor's order for this?
You need a doctor's order to physically assess the patient, yes, for hospice eligibility. Now, what we can do is we can talk to the loved one, right? If the power of attorney calls us and they say, here's all the changes that have occurred, and we could say, oh, they sound like they'd be hospice eligible, we can do a chart review and assess eligibility if we get approval, right? Because it's confidential, HIPAA, we have to, there's the rules we have to follow. But in order to be admitted to hospice, you have to have a physician's order, yes.
Okay.
But,
So could I
the one
call?
thing is even if they're in a facility, just to kind of tie in with what Carrie's saying too, we have patients who are in facilities and the family maybe comes to visit and they're like, oh, I don't think they look so good. And the facility nurse says, oh no, they're fine. You can always call us, even once they're on service. If they're at a facility, the families can always call us and say, we want you to come take a look at my mom, or we want, something isn't right. You can always call us. So the one thing that I had forgotten to mention earlier is hospice is available 24/7. So we cannot sit bedside 24/7 unless there are symptoms to manage. Remember how I said we don't leave someone uncomfortable. So we would sit there as long as it takes to get somebody comfortable and the family on board, everybody on the same page. That can take an hour or 7 hours, and we would stay there that whole time. But we can't just come and I don't want to say babysit, but we can't just come and sit with someone 24/7 a day. So that's when we work with families on if they need a caregiver or somebody personally to come into the home, a company and stuff. We help provide resources and work with them to get that in the home, but we are available 24/7. So just because a nurse comes at 10 o'clock in the morning and your loved one is doing great, but then at 2 p.m. or 3 a.m., they've had a huge change, all you do is call and we come. There is no limit to how many times we can come in a day, how many times we can see your loved one, holidays, weekends, after hours. I encourage people to ask their hospice companies. Remember how I said I'm a big fan of choice and interviewing? Ask your hospice company that's close to your area, what does it look like they're on call? Are they fully staffed on the weekends? Are they fully staffed on call? Because the thing is, I know a lot of you probably know, nothing happens Monday through Friday from 8 to 5. It happens on a Saturday at 3 in the morning that something goes wrong. So you want to know how quick is the response time. You obviously got to give them a little bit driving range, that sort of thing. But how quick is their response time? What's their availability? Those are all great questions, because hospice is always available 24/7, but cannot sit bedside 24/7 unless they're managing symptoms and making sure the patient is comfortable. So you can call as many times as you need to in a day. The other thing that's good is when you call hospice, there's always a nurse that triages those calls. So even if you don't need a nurse to come visit your loved one, but you have a question about medication, or you can't remember what the nurse said when they were there 8 hours ago, that nurse will have access and can talk you through things on the phone. So it's really nice. You don't necessarily always have to worry you're bothering them or something if you call, if that makes sense.
So do most hospice companies have the same nurse follow the same patient, or is that kind of just done for whoever's on call?
So I can't speak for other hospice companies on that, but what I can tell you is my company always has the same nurse case manager, and we try to do continuity of care. So we keep the same team members in for that patient, so it's less new faces that they're seeing. Now, that being said, and I do believe probably most hospice companies do try to do that. I just don't want to speak for them in one way or another, but I know that's what we do, is we do continuity of care, and we want to make sure that they're having the same team members. With that being said, if that nurse case manager is dealing with symptom management for another patient, or that patient has passed away, one of the things that we do is we never leave the family or the patient once they've passed. We stay with them and the family, until the funeral home picks them up. And our company does a really beautiful quilt ceremony when the funeral home does come. So we have our reasons for why we don't leave when someone has passed. So if the nurse is handling that or busy taking care of a patient, we don't obviously sacrifice the quality of our care. So she will be doing that. And we always have nurses that work very closely with our case managers that can come and see your loved one. So even though the nurse case manager is always going to be the same, the case manager doesn't change. The nurse that comes to visit may be, her partner that's helping her out, but would always have access to the information. And then our on-call team, we have the same on-call team for the evenings and the weekend. So even if you call every Saturday, it's going to be the same team of people coming, which is nice for the weekends and the evenings. And so, yes, so we do keep the same team. It's just, again, depending on a situation or if somebody's off or, something like that, we always have backup, which is wonderful. And they all have access to the patient's chart.
So is there a resource that you can recommend for people to kind of use as screening questions when they're making calls to the various hospices?
That's a good question. What I've learned is don't Google too much about any one hospice company. Because I have a background of working in the hospital type setting too. And I've done kind of a variety of things, but sometimes people are reviewing, right? They just read the reviews and maybe the review could be amazing. And then you use that company and the care is not what you thought it was, or vice versa. What I found that is best is to just interview every company that is in your area or that you see, because if you just go off of reviews or searching, all it takes is one person. It takes one person to make or break a situation. Really, you could go to the hospital and have the best nurse at the hospital in the ER. Your neighbor could go to the same hospital, have a different nurse who maybe is having a really bad day or doesn't, and could have a terrible experience. It takes one person to sway somebody in a good situation or bad situation. So I really feel if you go to I think it's medicare.gov, there's a list of hospice questions. So that kind of answers your question. Is there's a list of questions. I think there's maybe like 37 of them that you should ask the hospice companies. But I would, so that would be helpful, or just typing in like, what do I ask hospice companies? That kind of Googling is fine. But as far as looking at companies, I really recommend in-person, face-to-face, or phone interviews. You can tell a lot by meeting with somebody, talking to them on the phone. And the reviews just might not always be accurate when it comes to care, medical care. It might be accurate when you're, buying something off of Amazon or something, but when it comes to medical care of your loved one or yourself, even if you're, I really think not looking at the reviews or what their ratings are or anything like that, because every Heartland, for example, is nationwide. We have hospice agencies across, we have 4 or 5 in Illinois, we have all the different states. So one, that's kind of nice because we can, if someone's traveling for a wedding and they go to Florida, they can use the Heartland Hospice in Florida, right? And it's wonderful. But not every agency might have a strong clinical team. I don't know how the nurses are in Florida, so wherever your territory is at, or wherever you live in whatever part of the state, there might be a really amazing hospice company that's very local to your area versus overall. So I really encourage in-person interviews, over the phone interviews, versus just Googling and then going with whoever's the top rated.
Yeah, I've said in the past to people when looking for nursing homes, the same sort of thing. You need to do your due diligence. And, and I equate it to if I had that special occasion and I'm looking for that perfect dress for that special occasion, I'm not going to buy the first one I try on, nor am I going to try to Google it and buy it online because it might not look so good on me. And it might not make me feel good. So when it comes to these life decisions, it's much more important than shopping for a dress. My hospice decision, my long-term care decisions are extremely important. So I really need to do my due diligence and really try to make sure that I'm making the best choice for myself and or for my loved one. So
and I would just say for the skilled, like for the long-term care facilities, it's sometimes really good to not let them know you're coming all the time, which is hard with the pandemic, right? Because you got to like but if you can show up to a facility and say, hey, I'm here for a tour. Can I do a tour right now? I'm looking to place my loved one here. That's the best thing you could do is show up kind of unannounced, because that's, you're going to get it. Like, you're going to get in the mix of what they're doing on a day-to-day basis. They don't have time to, kind of like a daycare too, you know, when you like a daycare, like you, it's just better to kind of show up sometimes versus having a planned appointment where they know you're coming and they have, you know, I mean,
Right.
that's just my transparency with you guys. And you're exactly right. I always say you don't want to buy the first, you know, you want to feel confident and feel good about it, and it's got to be the right fit.
And Karen, who works with us, she put in 2 resources into the chat box that could help with those questions, as well as the Medicare. So one is from the Hospice Foundation, which again, I always say, go to the .orgs or go to the .govs. The .coms don't necessarily always give you that correct information as much. Katie, you know, the last question, I think, because we really have taken a lot of your time going over the hour, would just be, have you run into, I know some families have had, they've been told that hospice cannot come into the nursing home because they're in outbreak status. Could you speak to that?
Yeah, so every facility is different, I will say, and they follow different protocols and procedures based off of whoever their corporate level is or their company. What I would say is they've always allowed our nurses to either come into the facility at least every 14 days. So Medicare requires that a nurse does a visit on somebody that's on hospice once every 14 days at a minimum. So what we found is, even though facilities have stopped us from coming in or stopped our team from coming in, the nurses are either always able to get in and or do one visit and then maybe a telehealth visit over the phone with that facility. So it has been a struggle for us. I'm not going to lie. Sometimes it's hard because we feel we can't give our patients the best care, right? That we want to give them. But unfortunately, we have to do it based off of the facility and what they're going to allow us. Some facilities are very open and welcoming of hospice, and they're like, yes, come in as many times as you need to, it doesn't matter. And others have been more restricted. So that's been a challenge and is continuing to be a challenge as we're seeing the numbers rise and things happen. But knock on wood, so far our nurses are still very much able to get in. And even when it was the worst of the worst, you know, we were able to have the nurses in at least once every 14 days. We were fortunate.
And for the families, if your facility is not allowing your hospice in, call your local health department, because they're going to use that's their first excuse. Well, the local health department said, call your health department, guys. Ask.
Yep, and
make sure, put some pressure on them. Don't just let them skirt it off, because they're going to try to. So we as families have to help the hospice stay in.
And
yes,
I
and the
also
one
want to
thing
share.
is,
Go ahead,
oh,
Katie.
sorry. Some facilities too may not know the Medicare guideline of the once every 14 days. So that calling them and politely reminding them might help too. And maybe some of the facilities just don't know. They're not maybe as familiar with hospice, or, you know, some of the assisted living memory cares might not, you know, every place is different. So I don't want to misspeak to anything. And I know that they have to follow their guidelines just like everybody else does. So I don't want to, you know, speak for them, but yes, once every 14 days at a minimum, and definitely call. Hospice should definitely be able to get in there without a question.
So in anticipation of this call today, this meeting today, I did, Karen Trimberger, who's been working with IDPH, Illinois Department of Public Health, for the guidance. I posed that question to her because I just wanted to make sure that we were giving the proper answer. And she responded that hospice should be treated like essential caregivers. So they should be given access. So if Katie, if you or anybody that you work with as well runs into any barriers, please do reach out to, you can reach out to me even, and I can connect you with Karen.
Thank you.
Who will help fight for you, because this is obviously, if somebody's been given a doctor's order for hospice and or palliative care, they do deserve to be able to continue with that care and treatment throughout this pandemic.
Thank you. I appreciate that.
Yes, I know that that's something, that's something. And does anybody have any other questions that they would like to ask before we leave. I have learned so much, Katie, from you. Really, thank you.
I'm
Just
sorry, you guys, that I was late. I swear I was like 10 minutes early, but I was just in a different link.
different
So
location, a different room. And that's what
I
can
feel like
happen with
it
these
messed me
virtual
up a
things.
little bit. I was a little off at the beginning. I'm sorry. I hope I wasn't confusing.
You were
We
great,
appreciate
Katie.
it.
You're fine.
Yes. We so much appreciate you being here, and
Yes.
I apologize for any miscommunication that may have happened, but this is a world of crazy right now. And so I want to say
you.
thank you to everybody. We've had 25 people still stay on, but we had up to 57 people, I think, that were on the call to begin with. So we really do appreciate it. I'm
Thank
just going to
you.
put up a quick poll right now. For those of you who are on, if you could put this up, we've just been trying to just get an idea for how beneficial these programs have been. So if you could please just get on and just quickly give me this, hit this poll, I would really appreciate it. So thank you. Really, thank you very much.
Yes, and then just so that you guys, if you, I mean, Carrie, I know you and Lee obviously both have my email and my personal cell information. You can send my email. I think you have my personal email, which is probably the easiest one to use. You know, feel free, anybody in this group, if you are looking for more information or you just have additional questions, feel free to reach out to me. I don't push my company or a different company or I'm very transparent and open and upfront and honest. So please, if you do need to share my information, I'm okay with you sending out my email to everybody and getting in contact with them.
There was a question for what company you work with.
Oh yeah, so good question. So I am with Heartland Hospice, but there's different agencies. I am with our Northbrook Buffalo Grove office. However, we got bought back in 2018 by ProMedica, which is a big healthcare system out in Ohio and Michigan. And because we've been with them for 4 years, they never really rebranded the name. But now they are starting to change things over. So we are currently Heartland Hospice, but in the very near future, we might be called more of a ProMedica Hospice. But I do feel like they're going to keep the Heartland on for a little bit. So Heartland for now, maybe ProMedica in a little while, but it's all the same. The care is still the same. It's a not-for-profit company. Nothing has changed. Obviously, they've owned us for so long, and they just kind of stalled on rebranding. So that might be coming. So ProMedica or Heartland, either one, but I am with the Northbrook Buffalo Grove agency.
Got it. Okay. Thank you so much.
Sure.
And with that being said, I think that we've taken plenty of your time today. So thank you so much, Katie.
Thank you guys. And thank you for this opportunity. I hope you guys enjoyed it. Thank you so much.
Yes, definitely enjoyed it. It was very beneficial.
Thank you.
So much. And everyone have a good day. And remember, our next topic is going to be dementia-friendly Illinois and becoming a dementia friend, which will be presented by the Rush Alzheimer's Disease Center. So that's a really cool initiative. So we look forward to hearing everybody at our next meeting on September, the second weekend in the second week, 2 weeks from now. There we go. Okay, everybody. Thank you very much. Have a nice day.